transforming HIV in North Carolina, COVID, and ending the HIV epidemic. And without further ado, I'll pass it over.
Hi all, good afternoon. I was just telling Christina, this is the first time I have been in person in front of anybody except my household since March of 2020. And it is both wonderful and a little bit terrifying. I'm not gonna lie, it feels really, really different. So thanks to all of you for coming. Thanks to those of you who are Zooming in. What Christina and Janine have asked me to talk about is a little bit of several things. So I'm going to give you an update on where we stand with our Ending the Epidemic plan, which we did release in June of 2021. I also have to stop and think about what year it actually is now. But I also want to talk a little bit about COVID and how COVID has affected some things, and also give you some numbers. As Deshawn said a few minutes ago, it's kind of an epi report. There's a fair amount of numbers. And of course, you'll have the slides afterward and all that sort of thing. So let's go ahead. And if I can get my clicker to click. I do need the arrow forward button, right? Well, did it move? Ah. Okay, so as I said, this is the graphic, and I did bring hard copies in English and in Spanish for you all to take with the plan. But this is the graphic that we wound up with, that the steering committee gave their final okay on, and we were very pleased with it. So is it working now? So starting with some good news, because there is, of course, some not so great news with the effects of COVID on services and that sort of thing. But our HIV medication assistance program, HMAP, did add various new medications and increased enrollment this year, which has been a good thing, though, of course, part of the reason we had increased enrollment was probably because people lost jobs in healthcare due to the pandemic, unfortunately. Our PCAP, which is the program that pays for health insurance, expanded very significantly in 2021. Unlike previous years, now if you qualify for HMAP, you qualify for the premium assistance program. So people who want to sign up for healthcare on the marketplace, the federal marketplace, through healthcare.gov, we can cover them in the HMAP program if they qualify for HMAP. So we saw almost a 300% increase in people signed up for PCAP in 2021. We also have been able to put a lot more attention to oral health services, which we know is a huge and ongoing need for people living with HIV. And we have several initiatives that we've started to address stigma. And of course, we released the plan, which in and of itself was a pretty big deal in the middle of COVID. So first, let's talk a little bit about what we can see. And this is kind of the disclaimer slide. We do expect that all disease rates are probably higher than the slides in the testing show, because we know that disease rate diagnosis was decreased due to the pandemic. Many people didn't get tested, couldn't get tested. Health departments were having to do other critical things around COVID and couldn't offer the normal services. So indicators of HIV care, which have been steadily improving each year, plateaued in 2020, which probably means that it was actually lower than plateaued. Probably care services were less accessible than they were in previous years. So quickly, some words about STD testing. People obviously were able to access STD testing less. And it looks like some STDs decreased, particularly chlamydia and HIV, among people under 29, which is consistent with what we're seeing nationally. But these are diseases with fewer symptoms and are less likely to be diagnosed, since a lot of health departments were only seeing people who were symptomatic for their STDs. On the other hand, syphilis and gonorrhea are two STDs that have quite a bit of symptoms. And this is an important thing that I really want to leave with all of you. Syphilis increased by 47% between 2019 and 2021. That's with a decrease of testing of more than 50%. So we are across the state and very much here in Charlotte, we are in a syphilis epidemic. Once again, this is not new news. It's happened a number of times before, also consistent with national trends. But we have definitely got a syphilis epidemic going on. We are seeing an increase in congenital syphilis, people, women who are probably not aware that they have syphilis, and pregnant people who are giving birth to babies who are then exposed to syphilis. So you're going to hear more about this in months to come. We're forming up or work with health directors and with testers and with outreach workers to try to address this. HIV prevention funded work. This is the work that comes through my office, the funding that we get to help fund HIV prevention. And overall, as I said, our testing decreased by 54% from 2019 to 2020. We saw the positivity rate increase by a little bit. Maybe people were focusing more on highest risk populations, which would be a good thing. And previously diagnosed people who were tested by prevention agencies and already in care in 2019 actually declined from 80% to 66% in 2020, which may have to do with a decreased ability to get to their doctor's office. However, and this is tricky, but I thought it was cool enough that I wanted to include it for you. Previously diagnosed people who were not already in care and had evidence of an HIV care appointment after they were tested in 2019 was 21%. And in 2020, it was 63%, almost 64%. We think this is because we are better able to identify people and link them to services. So if you were someone who was previously diagnosed with HIV and you weren't in care, but we had some evidence that you'd had at least one care appointment after your test date, your linkage to care went up a lot, which was a very nice thing to be able to say. So let's move on to talking about COVID. And I'm sorry, excuse me, about the ending the epidemic. All I've done for 14 months is talk about COVID. So focus. So let's talk for a little bit about the Ending the Epidemic plan. As we said when we did our 11 community meetings all around the state, several of you that I recognize from those meetings, some of the folks up here were part of these meetings. We did 11 meetings across the state in 2019. We had 2 steering committee meetings at the beginning and at the end of working up the plan. And we said very clearly throughout that the state cannot do this work alone. We at the state level who push the funds out there and talk about what our deliverables and our outcomes will be are not the ones who are going to be able to actualize all of this. It really is a takes the village kind of scenario. We need the state, we need the local health departments, we need agencies, and we need communities to be able to pull all of this off. So what we know, again, is that our data has to be treated with caution because things like testing have been impacted by the pandemic. Also, anything related to care or our ability to address different parts of the plan, also very severely impacted by COVID, right? We know that most resources in public health were just full right turn to COVID rather than any of the normal activities. That was very much true at the state level with our Communicable Disease Branch. It was certainly true for all of the local health departments. And by the way, just a shout out to anybody who's been working in a local health department for the last 20 months, because it really has been hard. Just super, super hard. People have put in a lot of long hours and long days, and we're not done. It does continue. Hopefully we're seeing some downward signs of that now, but it's been hard work. So I have to give a shout out to all employees of local health departments. So What we did was set up pillars with strategies and action steps. We had 3 pillars, and I'm going to show you what those are. And we set up measures where we said, here's what we're going to measure and what we're going to look for as we start to take steps. So the first pillar was engage and embrace people in care. And the first strategy under that was to improve access to antiretrovirals. Lots of steps there that we said we wanted to do, like increasing access to transportation, leveraging transportation planning boards, taking care to patients, piloting rapid starts of ARTs, oral health emphasis, and increasing housing for people who are living with HIV. So those were the kind of key high-level things that we said we wanted to do for that pillar, and I will come back to kind of where we stand with some of it. The second pillar was, the second strategy under the pillar to engage and embrace was to normalize the assessment and to offer PrEP in all health services. PrEP education for health providers, which is important. We knew in 2019 that there was a very large number of regular primary care providers who didn't know about PrEP. They had no idea what it was. They weren't familiar with it. We wanted to identify populations who would be eligible for PrEP and find them in places like syringe service providers, in historically minority colleges and universities, et cetera, places where we might not automatically think to provide PrEP. And then we wanted to develop strategies to reach underserved populations, particularly people who were rural minorities, racial or sexual minorities. And then our third and last strategy in this pillar was to expand cultural humility training for all of our stakeholders. We felt that this was, and when I say we, by the way, I mean the communities that we spoke to, the many people who came together across the 11 cities that we went to across the state. I do not mean state employees thought this was important. I mean the people who helped create this. We thought it was important to provide training and education in cultural humility at all levels of service providers. We wanted to make it a new part of employee orientation. We wanted to ensure that the training is ongoing. We want to include people who are living with HIV, people with lived experience. We want to require funded agencies to evaluate the intersectionality of work and providing a welcoming environment to people who are coming to their clinics. And we wanted to explore partnership with medical and nursing associations to try to address stigma and look at cultural humility. So these were the things, the measures, the epidemiology parts that we said we would look at as the years roll by related to these strategies and that pillar. So I don't think I have a clicker. That's all right. What you're going to see on this is that we have definitely seen the effects of COVID. Things that we hoped would go up didn't. Some of the things that shouldn't have gone up did. So we're going to be working on, getting back. So this one is the percent of people living with HIV who are virally suppressed within 45 days of their HIV diagnosis. And you can see that from 2016 on, it was going up very nicely, and we were pleased with that. And then in 2020, it definitely took a dip. We did not get as many people linked to care and virally suppressed within 45 days as we would have hoped. So we have work to do on that. And as systems rebuild, people come back to clinics and offices, and we're able to do more outreach. Hopefully we'll be able to pick that up. The second measure for this pillar was the percentage of people living with HIV who are retained in care. And same thing, we were doing well since 2015, increasing the percent of people who were staying in care. But we saw a dip in 2020. And by the way, the percentage point for 2020, this one right here, if you can see it well enough, you can see it's slightly shaded. It's preliminary. We're still crunching the data on that. So the 2020 data points for the most part are still preliminary. But you can see that the percent of people who were retained in care did take a dip in 2020. And so we are not yet where we would want to be on track for the goals that we had, which is the line in green. The green is, I'm sorry, I should have said that. The green is goal, the blue is actual or preliminary actual. The next one was the percentage of people who had chlamydia, gonorrhea, or early syphilis, and who are also living with HIV who are not virally suppressed. And you can see that this one has bounced around a bit during the years. Our goal is obviously to bring it down a lot. We want people who are diagnosed with STDs to find themselves in care and virally suppressed as quickly as possible. It's an opening, a doorway, if you will, into reaching people who are living with HIV that we might not have otherwise be able to reach. When someone is diagnosed with an additional or a different STD, they're in a doctor's office somewhere, and it's an opportunity to say to them, hey, are you taking HIV medication? Are you on your ARTs? Let's get you linked up for that. So this is also a measure where we went up where we wanted to go down, and as life returns to normal and clinics return to normal, we will be working on this. And then the last measure under this pillar was the disparities in new HIV diagnoses. And obviously what we're looking for here is to try to address how people who are people of color, who are historically marginalized people, get into care and get a quick diagnosis and then a quick linkage to care. We want that number to go down, and it did go down a little bit, which makes me happy. That's a rate, that's the direction we want the rate to go. However, it didn't go down as much as we would like it to. And I have to say that it probably is also affected by our ability to test and get people into care. So it may not be as low there as is real. When we get the next year's numbers, we'll have to see what that looks like. So that's our engage and embrace pillar. We have done a number of other things, and I wanted to kind of bring some of that to you as well. COVID has normalized telehealth for a lot of people, you know, suddenly, and we all know this, suddenly and without warning, telehealth was the way we did things. And there had been a lot of conversation prior to COVID that this was a good opportunity, that it reduces the issues of transportation. It kind of levels the playing field for people who are in more rural areas or who don't have cars or who don't have childcare, and therefore leaving the house and getting to a doctor appointment is so much more complicated. But with COVID, telehealth became the norm in the way that we did things. So there are some silver linings, I think, to COVID, and that's one of them. Suddenly, telehealth is a much more normal way of accessing your medical care, and that's a good thing. We did are piloting 2 rapid ART deliveries in North Carolina now. We have one at Winches in Asheville, and we have one at Carolina Family. So we are working on the best way to get people onto their ARVs literally at their first appointment. COVID complicated that because not nearly as many people are coming in as they were, but in those 2 clinics where we're piloting this, every single person who came in for their first appointment left with their medication, started their pills at that day on that hour. In many cases, they told me, I talked to them earlier this week, they were handed their pills and a glass of water, and they took their first pill while they were sitting in the office. That's a really big deal. And one of the things I really wanted to know from those 2 clinics was whether they had to convince people. Was it a big sell? Was it a big conversation? Were people worried? And what they said actually was intriguing to me. They said that almost without exception, they didn't have to convince people. People were anxious to start their meds right away. I count that as a victory by the testers, the people who delivered the news that a person was living with HIV now, because they quickly normalized it, explained what HIV is and is not, and explained the importance of medication. Used to be that people didn't feel nearly as calm about starting medication for HIV. So I count that as a huge victory, and it is our hope to roll out this pilot further so that we can increase access to ARVs at that first appointment across the state. We have created an oral health task force. We're holding regular discussions. We did have one in-person oral health meeting, and we're encouraging networks to budget more of their funds for dental care. The funding that we have for HIV care is through the Ryan White funds from the federal government. It has not increased in many, many years. So when we're encouraging agencies to budget more for oral health, provide more dental care, that also means they have to slice that money off of something else. The pie didn't get bigger, so the slices are getting smaller or larger depending on how you cut the pie. We did get an increase in HOPWA funds, housing opportunities for people with AIDS. That comes from the federal government also. We were able to increase the funding available to the networks of care and prevention through our 2021 request for applications, our funding mechanism. And we're talking about ways to provide better access to HOPWA funds. We need to be sure that that's getting to more people. We're even looking at the possibility of whether there are other agencies that we should be bringing into the fold who would be able to do housing better. So we'll see what happens on that. But it's very clear that we have money. In fact, this is one of the few areas where funding has grown, but it's not getting to the people who need it. And there is a federal government reason for that in large part. They have a market index and you can't assist if the rent is too high. And as we all know, the rent is too high literally everywhere these days. So it's, yeah. Too high. And so if you have found an apartment and your agency is saying, yes, we can help you pay for the rent, but the monthly rent is higher than the federal government allows, then the agency is not allowed to assist you with the funding that they're sitting on, essentially. And it makes everybody nuts. It's a crazy system and extremely frustrating. And we need the federal government to work on changes for that. And then the last part here, we have during the course of the pandemic developed new state level medical case management training. We put together a committee, including people with lived experience, to decide what that should be and what should be in it, and to give a better education for new case managers coming into the field for HIV. We also have funded 4 regional and 1 statewide PrEP coordinator to conduct PrEP service coordination, to verify PrEP appointments, and to increase our provider education for PrEP. We're requiring all of the agencies who are funded through my office to educate clients about PrEP. So if someone comes in for an HIV test and they test negative, awesome news, let's talk about PrEP. Because if you needed an HIV test, you probably should be considering whether or not PrEP is the right choice for you. So we want to be sure that all of our testing agencies and testers are able to clearly, coherently explain what PrEP is and make appointments for people who are eligible and interested in PrEP. So we're trying to do a very warm handoff for people who test negative for HIV and might need to be on PrEP. And then finally, we have new work in process that highlights people who are living with HIV plus an STD, who are not virally suppressed for their HIV, to work with our state and regional bridge counselors to improve their outreach, to improve linkage to care. Again, as I said before, when people are living with HIV and then they test positive for an STD, if they're not already virally suppressed for their HIV, it is a perfect opportunity to try to get them into care. Okay, second pillar, testing and treating, the test and treat pillar. First strategy was to expand and increase testing for all HIV, STD, and hepatitis in traditional and non-traditional testing settings. So I'm not going to read this word for you, but to increase testing in traditional, non-traditional, and non-clinical places like clubs, mail-in, hair salons, nail salons, SSPs, syringe services programs, the DMV, et cetera, as well as wellness events, dental offices, mobile testing, all of those ways where we can try to reach people. In jails, we do test in 28 jails across the state already. And of course, the more we can do that and the more the local sheriff's office will let that happen, the better it is, partly because we have an audience there who is generally at higher risk and they're generally open to testing. We look at substance use centers and increasing testing for emergency departments as well, which is a harder lift. It makes perfect sense to do it there, but there's a lot going on in emergency departments at any given moment. And I will tell you, we have not even tried since March of 2020 to have that conversation with emergency departments. I don't know if any of you have been there. I was in one not long ago with a family member, and there weren't even enough chairs to sit in. It was so full. So emergency departments are not going to be able to increase their testing services anytime soon. That is absolutely a byproduct of COVID. So we're going to look at the next strategy, assuring that HIV and STI education for providers includes anti-stigma education. As I said before, we want to train providers on cultural humility based on best practices when testing people and the knowledge of HIV science and treatment and prep. We want to assure that cultural humility training includes things like sexual orientation and gender identity, racial and sexual minority, people with lived experience, and that we do it in a trauma-informed care network framework. And then we want to talk about education about best practices for HIV and STI testing and who should get tested. And then the last strategy in this pillar, social media campaigns to promote HIV testing and prevention and reduce stigma. Again, this is one we have not been able to do a great deal of. We did hire someone, one of Esther's colleagues, as a matter of fact, Luke Keeler, who is our guy at the state to help our funded networks and health departments work on this. He was hired and then promptly sucked straight into COVID full time. So, which was okay because the health departments were also full-time in COVID. But we want to help the local health departments and the agencies with their social media. We hope to create a statewide media campaign to promote HIV testing and prevention. We want to have a well-developed language access plan. And let me pause on that for just a moment. We are in the process now of reworking our website for the Communicable Disease Branch at the state level. And part of that, when it's done, will include the option to hit the button and translate it into any language. We're really pleased with that. It's not done. Again, we have not had time to look at it in the last 20 months, but we've started that process now, and eventually that will happen. And I believe it's Mecklenburg County whose website, am I right about that, Jeffrey? You hit the button and it will translate the entire thing into whatever language you want. One of the health departments, I'm pretty sure it's Mecklenburg, has a pretty impressive language access website that's pretty awesome. I did, by the way, bring hard copies of the Ending the Epidemic plan in English and in Spanish, and they're here. You'll see them. So, and Janine has one in her hand. I can't see from here. She's got both languages. All right, good. And they'll be over there. So please take them with you. Feel free. I have more in my office, so we have plenty. And of course, we want the messages in these campaigns to include people from our focus community, people with lived experience. We want to confirm support for people living with HIV that includes transgender people and gender nonconforming people. And we want to uplift and empower. This is a campaign and a message that should be uplifting and empower people. So here are the measures that we agreed to. The first one, the number of new diagnoses per year, we want it to go down. And as you can see, the blue line, it did go down, and that should be good news. But remember what I said a while back, testing went down by 54%. So unfortunately, I have to say the caveat in this is that the next blue point that we put in there will probably be up, because this is probably not as reliable a number as we would like it to be. We want it to trend down. We'll have to see what happens. The rate of new HIV diagnoses, and just a quick epi tutorial. Rate is important because it takes into account the size of a community, the size of a state. So the number of people on this slide here, that's great. You can see that in 2020, it looks like we had about 1,100 people who got a new HIV diagnosis. So that's the number, but rate tells you what it looks like per 100,000. So it takes into account how many people in a population and what that rate looks like compared to other populations or other states, whatever. And again, we want it to go down, and it did, but probably we will see an increase in the following year. The rate of HIV diagnosis late in disease course, this is people who are diagnosed with HIV and AIDS or HIV and advanced HIV illness at the same time. Again, we want that to go down. We want to catch people early on in the course of living with HIV so we can get them on medication, and so their immune system is improved and they are not vulnerable. And these are small numbers. Actually, you can't quite see them, but it's 0, 1, 2, 3 right there. So these are very small numbers, and it plateaued. And again, of course, we want it to go down. And plateau is actually quite good, but it's a very small rate, very small slides. So, and let me just say something quickly about COVID and HIV. I have been asked this before in kind of remote meetings. We have not seen that people who are living with HIV have been impacted disproportionately by COVID. Deaths are not up for people living with HIV who died of COVID. We've had about 48 deaths across the state of people living with HIV who died of COVID. What we can see with our various databases, and we actually have really excellent data. We're very fortunate. North Carolina has some excellent epidemiologists, and we have some excellent data sources. What we're able to see from that is that people living with HIV have not had a disproportionate number of diagnoses with COVID or deaths from COVID, which is really excellent news. And I think a big piece of that goes back to viral suppression. If someone is living with HIV and they're virally suppressed, then their immune system really is quite robust. And if they're exposed to COVID or they get sick with COVID, they have an immune system that's acting pretty normally, as opposed to an immune system that is badly depleted before their COVID diagnosis hits. So I do think that the efforts that we've done over the many years and the efforts that you all have made over the many years to get people virally suppressed when living with HIV has meant that our community of people living with HIV has not been badly harmed by COVID, and not more than anybody else living with COVID. Okay, so some related efforts around the test and treat pillar. We are supporting 27 agencies for counseling, testing, and referral in non-traditional settings. We're also supporting 30 agencies for rapid testing. So that's, you know, the quick swab or pinprick that gives people results very, very quickly, you know, within a couple of hours. So we've got quite a bit of testing going on out in the world. We've developed a technical assistance plan with the Latino Commission on AIDS to provide technical assistance to access high-risk populations and to use media more effectively. So this is TA for our agencies and health departments that the Latino Commission has helped us develop. We've contracted with a company called Building Health Online Communities to support free at-home testing. That is new. It popped up at the very beginning of COVID. Like most things on the state level, it takes a while to get a contract in place. We have a contract in place and it is just kicked off. It's going to include ads in MSM dating sites, chat sites, so that clients or people can order HIV tests that are shipped to their homes, that are free, and can include risk reduction information and confirmatory testing site information. So I'm very excited about that possibility. We have not been able to provide that, much less provide it for free in the past. So this is a new step, and one that even though it took a little while to get in place, is another step toward helping people access their testing. And then we move to the last pillar, policy and promotion. We have a couple of strategies here. The statewide promotion of U equals U, undetectable equals untransmittable. And I will be honest, we have not been able to do that in the current environment. So this one doesn't have a lot of activity that has happened, but we are hopeful and do plan to pursue that in coming times. The second one is to promote youth serving sexual health programs, fostering collaboration with youth serving health, lots of faith-based organizations, academic institutions, et cetera. Encourage the creation of local task force to inform parents and guardians about the Healthy Youth Act from 2009 about accurate sexual education in schools, and engaging local school boards and PTAs. And I think this pillar in particular is something that will have to happen on the local level. And when we created this particular strategy, there was a lot of conversation, because this is not something that's going to work very well from the state coming down. This is very much about local communities, local agencies, local health departments working with their communities to do this, because every community is different. Every county is different. And what's going to work in Mecklenburg County is probably going to work very differently if you take it to Burke County. What's going to work in Dare is not going to work in Cherokee County. So, you know, it's definitely not a one size fits all campaign. It is a local county by county and community by community effort. And then our last strategy is in partnership with NCAN to raise awareness in communities and with key stakeholders about the benefits of closing the coverage gap. This is certainly about expanding care funds at the federal, the state, the local level. And it is very certainly about educating about the benefits of expanding Medicaid, because we have quite a few folks who, because we are not a Medicaid extension state in North Carolina, we have quite a few folks who are not currently receiving health insurance. And we know that that is the single best way to make sure that people are in care and virally suppressed. And while we have the HIV medication program, which serves people 300% of the federal poverty and below, if you're above 300% of the federal poverty, we can't cover you. We can't pay for your medications. And that is a coverage gap. And it's a pretty wide coverage gap. And as we've seen people lose jobs that sometimes had health insurance, this is certainly an issue that's been impacted. So my understanding is that conversations are still happening about expanding Medicaid in North Carolina in the coming year. The General Assembly and the governor are apparently still talking about it, but I don't have any insight into how it's going. And I think the, be sure you vote, be sure that your personal representatives know how you feel about it, continues to be a really important part of how we make change in Raleigh. So a couple of things that we said we would look at. The rate of people who are on PrEP. This is actually one of our best good news slides because the rate has gone up. We are definitely seeing more people on PrEP than we used to. And we are actually higher than we had expected to be. And since these are real numbers, it's probably not an artificial number. It's probably not impacted by COVID. We were able to look at some things actually just this week in preparation for this conversation. We were able to pull together some other data, and we were very pleasantly surprised to discover that we have more people on PrEP and that the rate has gone up quite a bit more than we thought it had. Then we looked at the percent of counties with a PrEP provider, and as you can see, it didn't go down. And that's a yay, given the 20 months of COVID, but obviously it didn't go up either. It plateaued pretty significantly. Obviously we want it to go up and up and up, but the fact that no counties lost their PrEP provision of services was at least something in the crazy environment that we've had during COVID. And then we looked at some stigma measures. If you remember, we said at the beginning, and we talked very clearly with the communities, that stigma and addressing HIV stigma needed to be woven throughout everything we did with ending the epidemic. It was very clear, and those of us on the state, local staffs felt very strongly that stigma about living with HIV is still very, very much with us in 2020, 2021. Even stigma about taking PrEP is a thing and is real. So the idea of trying to address stigma is critically important. And we came up with two measures to try to measure it. The first one is agreeing that having HIV makes me feel like I'm a bad person. And obviously we don't want that to be a high number. I asked our epidemiologists what happened in 2017 and then 18 and 19, because it looks pretty stark. And our surveillance chief pointed out that the percentage is actually not very high. We're going from about 6% to about 14%. So even though it looks like we're rocketing crazily, it's not as much as it looks like. And it could have simply been a sample size. The sample size for all of these data points is the same. It's through a medical monitoring project that we do with CDC, where we talk to real people living with HIV in North Carolina to ask them these questions. But it's higher than we want it to be, and we had hoped it would be going down, and we've got work to do, obviously, because there are a fair number of people out there who reported that having HIV does make them feel like a bad person, and we do not want that. The other measure that we looked at is I have been hurt by how many people, I'm sorry, let me say that differently. I have been hurt by how many people reacted to learning that I have HIV. It stayed pretty steady, went down a little bit. We want it to go down a lot more. We don't want people to feel hurt by how others react to learning that they're living with HIV. So some words about what we've been doing. This is our biggest one, and I'm super excited about it because we just locked it down. We have spent this last year working with the HIV Training Education Center, HTEC, used to be called ATEC, at UNC to create a cultural humility training. We've just locked that in. It will be, actually that is a typo. It will be implemented on February the 4th of 2022. I just gave a talk about this yesterday. We're going to do it quarterly. We're going to require that any positions or agencies that we fund will have to attend. Each quarterly session will be 60 minutes of didactic information delivery, followed by discussion. And the 4 topics will center on principles of cultural humility and implicit bias, and then racism, and then homophobia, and then transphobia. It's also our plan to look at how you put that kind of training into practice. What do I do with this when I go back to my agency? What do I do once I get trained? Once I am a little more woke than I was before I got this, what do I do and how do I make effects on the ground? We're pretty excited about that, and we'll hear more about it because it's mandatory if you get funded by us. So we'll have good attendance. We also created a peer support specialist program. We drafted up guidance for a state-led peer support specialist. Then we started getting guidance and clarification from the feds, both HRSA that funds Ryan White funds and CDC that funds our testing efforts, that we can't use their funds to create a peer support specialist. So we have a curriculum and agencies, health departments can use that, but they have to use other funding. And certainly right now, that's a pretty tough lift. We were more than a little disappointed the way that turns out. Other states are doing it, but they're not doing it with federal funding. They're doing it with program income funding, or they're doing it with their own state funds, which we don't have, unfortunately. So the guidance for peer support specialists is available to everybody. We'll keep looking for funding, but this was one of the other things that we heard loud and clear when we did community meetings. People said very clearly, I don't want to hear about HIV and how to live with it from you, Jacquelyn. I want to hear about it from someone who already has lived experience. And that, of course, makes complete sense and is the way that it should be. So we took that to heart and thought we were going to be providing something that it turns out we don't have a mechanism to provide, at least at the moment. But it is there, and there are agencies within North Carolina who are doing it. Winches, again, out in Asheville, has a peer support specialist, and they said that that is the first person who meets someone who's been newly diagnosed with HIV when they come through the door, and that it's very effective, which makes sense. Addressing stigma. We have removed the word AIDS from pretty much everything. AIDS is simply part of the continuum of HIV, and it's about the state of one's health. It is generally considered a stigmatizing word. Now, there are a number of people who have been long-term survivors of HIV and who have expressed some concern about removing the word AIDS. They feel it detracts from their long-term experience, and we have folks who can talk about that. So it's a tricky conversation for sure. We have improved our data and our response with the data to collect for transgender people. And just to point this out, due to historical and current stigma, the total number of transgender people in our HIV surveillance system is likely to be an underestimation. It is a self-reported number, And frequently we know that people probably do not identify themselves as transgender in certain settings. We did create a series of DIS, disease intervention specialist sensitivity trainings around that issue of transgender data and making sure that we give ample opportunity and comfort so that people can choose and express the gender identity that they want to. We did change the control measures in 2018 so that if a person is reliably virally suppressed for 6 months or longer, they do not have to tell their sexual partners that they are HIV positive. That was a very big change. We worked with NCAN, we worked with Christina, and we fought that through and had a lot of conversation about it and changed the law in North Carolina. And again, each pillar in ending the epidemic in the plan does have at least one strategy that emphasizes stigma. So that is everything. You can find me at that email address, and you can find the plan at that website. It is on our website, and that is the link. So I want to thank you. If you have any questions, I can answer now, but I know we also have some. Okay, we're going to keep going. Christina says no, keep going. So I will hand it on to the next speaker.
Yes, thank you. You can pass this mic here. We're gonna, thank you so much, Jacquelyn. That was amazing. I feel like right now with this conversation, I thought that we could have different perspectives. Obviously, we have the OG here from the state being able to present the results of the plan that a lot of folks in this room and folks that are watching participated in. You know, we took the time to go to a lot of different cities in this state, cities I had never heard of, counties I had never heard of. And it was important to do that, even though it's hard work, but it's the way that the work needs to be done. And I think that even seeing some of these results when it comes to stigma, when it comes to these trainings that your folks will be invited to attend to, you know, that was something that came from the community. And it's like, we can't afford to have folks elect to take these trainings. Folks are dying. They have to do it. They have to learn. So I thought it would be cool to talk to folks who were a part of that process, and then also kind of tie in themes that we've been discussing throughout the conference. Obviously, COVID is never, you know, too far from us. And, you know, it impacts all of our work. It impacts our lives. You know, yesterday we talked about harm reduction. We talked about drug use, and that could impact our lives. And, you know, COVID isn't exempt from that. And there's a lot of mixing syndemics that have been impacted by each other, and we've created additional issues. But I feel like it could be great to be able to kind of just like talk about that real piece, and talk about the resources that are available, you know, when it comes to healthcare. Because I feel like more broadly, especially for folks in this room, you know, we're wanting to end HIV, and it's not just going to take a pill. We may need to get more funding, maybe to change legislation. We need to, you know, do a lot of different things. So it's like, we want to know what tools are available. Can we utilize the Medicaid program? That's in existence, but we're in North Carolina, we haven't expanded. So, you know, there's a lot of questions that we could explore. We are short on time. We're going to try to make this as quick and snappy as possible. But I just wanted to have the panelists here just quickly introduce themselves, and then we'll get started with some questions. So we'll just go down the row.
Great. Hi, I'm Julieanne Taylor. I'm an attorney with the Charlotte Center for Legal Advocacy. I primarily work in the Family Support and Healthcare Unit, helping people access public benefits like Medicaid and marketplace health coverage.
Good afternoon, everyone. My name is Esther Ross, and I am a person living, surviving, and striving with HIV for 28 years. I'm a community member, and I'm just glad to be here.
Hi, I'm Jeffrey Long. I'm from Cherokee, North Carolina.
That's all we need. We're gonna get into the questions.
Well, I just got cut off.
Sorry. I didn't know if you were gonna go into a spiel. I'm like, we're gonna have plenty of time to talk, but we have like 18 minutes. I want to make sure that we get questions in. So sorry, Jeffrey. Apologies. I'm sorry for being so rude. But I did want to piggyback off of what Jacquelyn was just talking about. I know that both you and Esther were a part of the steering committee, and I'm curious to know what your experience was like. If you can remember back to 2019 with all the meetings and all of that, what was your experience like? And yeah, go ahead, Jeffrey. Since we cut you off,
Since
I
you
cut
cut
you
me
off.
off,
You can go ahead and
um,
go first.
My experience with it all was very enlightening because we set up a plan to try to end this epidemic by the year 2030 was that the goal. And we did go across the state and everything and set up meetings, and we had one way down in Bryson, and Christina was kind of scared of that area.
It was so far.
Yeah.
I'd never been there.
But my experience with this is, like I said, it was an enlightening and a learning experience, more information in my head. So,
Thank you. Esther, what was your experience like?
It was very empowering because it was an opportunity to not only bring about some community perspectives surrounding, people of lived experience being part of the process, which I think is so important to that, it has to be a collaboration on a part, just like Jacquelyn was sharing, we lack community resources from the state. So now we have to look within ourselves to build that resource so that we can really address, ending the HIV epidemic. And I was real glad to be a part of that process. So I felt empowered.
I love that. I love that. Feeling empowered. That's always the vibe. All right, so to COVID, switching gears. Obviously, during that time, a lot of people experienced a lot of economic stress. Aside from just having to worry about getting COVID, it's like, how are we going to pay bills? How are we going to pay for food? And that obviously has an impact on your health. Whatever the kind of stress may be, fear of COVID, fear of, money, that's really stressful. And I'm curious to know, when you think about stress and then you think about how folks cope with stress, drug use is one of those coping strategies. But, how do you think, the economic stress and all the other stresses that people experience, plus COVID, plus, substance use, like how does that all tie in together in your experience? If you talk to friends or peers, and have you heard what people are thinking about?
As a community advocate, I've been a community advocate for the majority of the years I've lived with HIV. And when I got here to North Carolina, the advocacy continued. When, with stigma, and then individuals that are experiencing lack of housing, lack of health insurance, lack of employment, lack of transportation to even access the services that they need to stay in care. And so with the onset of COVID, it made that just more pronounced. I've been a part of a life skill support workshop, and it's comprised of people HIV 50 and over. And we've been involved with community advocacy and everything. And some of the challenges are that although telehealth is a good thing, many don't have the apparatus to access telehealth.
You mean like no Wi-Fi?
No Wi-Fi, or, you know, the smartphone, really, some people are still using flip phones. And you can't access telehealth that way. So it just, as that's, you know, just made it worse. An issue that was already stigmatized, and now with COVID, it's much more stigmatized. And I've actually, it's a couple of people that I know HIV positive and died from COVID. You know, so it's a challenge. It's very challenging.
Jeffrey, what have you been hearing?
All the stress really depletes your T cells as well. So that's another health issue. My mother caught COVID back in January. I took care of her for about a good month and a half and brought her back. It was just horrifying to see someone in that position. My experience, well, that was my experience. The economic stress would be, like you guys said, paying bills and food on the table and everything like that. In Cherokee, we had pantries, food pantries that came through and helped us that way. So,
Speaking about healthcare, why don't we switch gears a second? I want to ask you two a question. I'm ask the same question to all three of y'all, but I'll ask you two first. When you hear the words Medicaid transformation, what does that mean to you?
I haven't heard.
Esther?
You know, me being out there, yes, I've heard about it. Medicaid managed care. I'm not, you know, too familiar with it to the extent that I know all the details about it, but pretty much it still is the people who need Medicaid the most are not accessing it through this program. I would love to see Medicaid as a whole be expanded, period, for North Carolina, and not this managed care system, particularly among people living with HIV 50 and over.
For sure. Esther, we're working on the Medicaid expansion piece. Be patient.
Okay.
So don't worry. But I asked that for a specific reason, because obviously, like, I work in this space and I hear Medicaid transformation, and I'm just like, that probably means nothing to most people. But then once their provider may change or their, you know, clinic may change, it's like, oh wait, this is real. What is this? What is this? So, Julianne, Jules, what is Medicaid transformation?
Well, that is a great question. And we don't have all day.
We don't.
So I will try to make it brief. So North Carolina, obviously Medicaid expansion would be ideal, but that we didn't get that. We got Medicaid transformation. So essentially what that means is instead of the state managing care and having one network of providers in the state, now they've contracted with 6 insurance companies, they're private insurance companies, and they manage people's care. So what that meant was that, and that occurred this year. So that's for 1.6 million North Carolinians, primarily individuals that are in family and children's Medicaid programs. So what that meant was that they started to get notices, and these are individuals who have maybe been on Medicaid for years. They haven't seen any changes. They don't understand why there would be any changes. And all of a sudden they're getting a notice in the mail saying, you have to call an enrollment broker and you have to enroll in a plan. Well, they're like, do I have to pay for this? Who is this? Is my doctor in network? Are there going to be copays? What are the changes? And unfortunately, the messaging was not clear, and it's still not clear. And so the state actually contracted with 3 legal aid agencies across the state: Legal Aid of North Carolina, Charlotte Center for Legal Advocacy, and Pisgah Legal Services. And they provide a program called the North Carolina Medicaid Ombudsman. Ombudsman is a terrible word. We tried to push very hard against that. We said, you want all of our reading material to be 6th grade reading level, and yet ombudsman is like 14th grade reading level. I went to law school. I was like, what the is an ombudsman. I don't even know. Like, it was just insane. But anyways, they were like, no, you have to go forward. This is what we're doing. So we did it. And so they contracted with those agencies in January. We've been working on that program. And what that service is when people have questions or have no idea what's going on, who to go to, who to call, they aren't getting the transportation that they need. The provider says that they won't see them. They're not getting access to the services that they need, and they've enrolled in one of these standard plans, which is one of the 6 private insurance companies, that they can call the North Carolina Medicaid Ombudsman and get connected where they need to go, get their questions answered. If they don't know the answer to the question, they will do the research and figure out where that person needs to go, and they will get follow-up within 24 to 48 hours. So that resource is available in the community. For individuals that don't qualify for Medicaid in North Carolina, because as we've talked about and most people in this room know, Medicaid in North Carolina is incredibly limited. So for individuals that don't qualify for Medicaid, there are marketplace plans. Anybody can enroll in a QHP as long as their income is between 100 and 300% and still qualify for premium and copay assistance for individuals living with HIV/AIDS. And so those options are out there. I also want to mention that there is the North Carolina Medicaid, the North Carolina Navigator Consortium. And that is a statewide program. Their phone number is 855-733-3711. And they can help answer any questions about Medicaid and Marketplace and help people actually enroll. Enrollment is November 1st through January 15th.
Okay. Did you want to add a clarifying something?
Yeah, I just want to clarify one quick thing. As I said at the beginning, the HMAP, the HIV Medication Assistance Program, formerly known as ADAP, we are covering all clients 0 to 300% of federal poverty on the ACA marketplace. We will pay their premiums. So it used to be 100 to 300% FPL. It's now 0 to 300% FPL if you're on that program. So people have to apply in the marketplace, but that does exist now.
So it's like Medicaid expansion light for HIV, people living with HIV.
And just one clarifying thing, you still have to have income between 100 and 400% to qualify for subsidies in the marketplace. But even if you don't qualify for subsidies, so if you're in between 0 and 100%, HMAP will still cover those premiums without a subsidy. Not confusing at all, right? That's so easy.
Okay, so tell your friends. We have 5 minutes and we had a bunch of other questions we wanted to ask, of course, but that's how it goes. So I'm just gonna leave it open and I'll give everyone an opportunity to share something that they would have loved to have shared, been asked, something you think is important, what brings you to this work, something like that. I think that'll be a good way to end.
So I just want to say that, in the work that we do on a daily basis, what we constantly hear is just that I didn't know that this service exists. I didn't know this was available to me. I didn't know that I could access this for free. They always think that there's a catch or there's something there. And so I think that having conferences like this and working together, being a community and making sure that we are all as advocates aware of the programs that are out there and making sure that individuals on the ground know that there is no catch, people are available and they can do it. I feel like that's a sign I should.
No, you just need to, you deserve a little soundtrack, that's all. Go ahead, Esther.
So I'm in this work. I really, because me and my husband both got COVID at the beginning of the year. And it was the most, out of all the years that I've lived with HIV and going through multiple health conditions, because I look nothing like I did when I was first diagnosed. I was told I would be dead in 3 months. In 1993, I was 99 pounds. I was on drugs, everything. I just celebrated 25 years clean and recovery. And you know, you could see I've gained some weight. But one of the things is if you can prevent it, just like with HIV, if you can prevent it and get the vaccine for COVID, you know, I've lost me and my husband lost our family members, my oldest brother, sister-in-law to COVID. If you can get the vaccine, please get it. If you don't know your status, please get tested so that you can get in care. And that's how we'll end the epidemic and also this COVID pandemic.
Mhm. Jeffrey, share some
I want to
things.
talk about the word AIDS and why are we taking it away? Because we have people, long-term survivors, that we're pretty much erasing if we erase the word AIDS. I was diagnosed with full-blown AIDS. I know we don't say full-blown anymore, but the AIDS, it's like a type of, like a badge of honor.
Mm.
So if we're taking away that because it's very stigmatizing, then we're taking away a lot of people that have been diagnosed with it. And you have a different feeling on that too, don't you? You'd rather use HIV?
I'd rather say, you know, I became a social worker, and I believe with positive reinforcement. And I think everyone has their own strength within them. And how I got better was, you know, I had to feed myself positive. And with me working in the community, if I can hone in or help you identify the power that you have within yourself, because it's not only stigmatized from the public, it's that internal stigmatization that prevents us from linking to care, staying in care. I want to live long and healthy. I'm 60 years old. My life is just beginning, and I want to do everything I can to stay here. So yes, saying HIV, just so that we can decrease that stigma and increase positive so that we can get to a point where everybody is talking about it. Because, just like someone was shared earlier, I would love it to be able to share, today I'm not feeling that well. I get pain all the time. I just went through back surgery. I get pain all the time. Some days is better than others, but I know it's a direct result of the information in my body being HIV positive for so long. And I have to be careful where I share that with.
Mhm.
In the spaces that I have to be careful, because it's not only me, it's my husband, it's also my children. I have to be careful. And it shouldn't be that way because I'm living long, just like I said, strong, healthy, striving, and thriving. And might I admit, sexy at 60.
Yeah, you are. Oh, thank you. Because I feel like, y'all went into a great conversation, with the HIV and AIDS distinction. And that's been an ongoing conversation throughout the broader movement. And there are people on both sides of that. And I feel like everything's valid. All of the opinions and thoughts are valid. Like everything y'all said is true. Like you don't want to be erased, but then you also want to be able to, encourage folks, like, and not scare them. That should be a session. Maybe we can talk about that at next year's conference. But yes, thank you so much for all the panelists and presenters that joined me today. Y'all are great. Round of applause, round of applause. Yes. Jeannie, do you have some announcements?
No, I just wanted to make sure that everyone on the panel feels free to get a t-shirt on the way out. And I think our next workshop is we do have a couple of them.
Yeah. I know.
Like, could you read my mind? Excuse Okay, I need to look at this for 1 second.